So I think that, again, if you have that action plan, all of the products, I have pictures in the green and yellow zone, and once you've had that discussion, it really allows them to think like, oh, she does know what she's talking about.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today? Oh, no, Raja is not here with me today. Oh, my gosh. Well, folks, it's just you, me, and our mystery guest today. We're going to talk a lot about a very common issue that we see in clinic every day, and that is atopic dermatitis. And those of you there are saying, wait a minute, atopic dermatitis? I heard about it just today or yesterday. Well, we will try to put a different spin on it because one of the more challenging population are the pediatric or the very early infant kiddos who have eczema, where you're really dealing with parents and parents who may be very scared and very unsure of what is coming next. And so we need really good foundation on education and really finding an in with these patients. And so we wanted to have a guest who could really help guide us through this. And so I can't think of anyone better than Sam Casselman, who's a pediatric nurse practitioner in Phoenix, Arizona. Hey, Sam, how are you?
Hi, Hadar. Thank you so much for having me.
Of course. And let me introduce you briefly. Sam is, as I mentioned, a pediatric nurse practitioner. She owns her practice called Happy Skin Pediatric Dermatology. That's a cool name. Makes me happy. Definitely makes me smile. Where she specializes in infant and child atopic dermatitis. And Sam is affiliated with the National Eczema Association and is a current executive board member for the National Association of Pediatric Nurse Practitioners. So, Sam, welcome to the program.
Thank you. Thanks for inviting me and talking about this topic that a lot of us may cringe a little bit when we think about appointments with a 3-month-old and their family. We can all guess the themes that we'll be discussing, but I spent a lot of time at the local academic institution here in Phoenix, about 2 years as a nurse, and so I got a lot of the same types of calls, fears, themes for worries around this topic, and that really fed into my passion around pediatric eczema and creating eczema schools at that institution before I left, and now being able to develop my own way of working with families and that shared decision making, which we all enjoy to do. But I really feel that there's a couple of nuggets that I can provide that hopefully will make the visits easier for our listeners here.
Amazing. So let's just dive into it because you mentioned eczema schools, which is a model that hopefully is expanding around the nation. I know it was started in Europe and then pioneered here in the U.S. as well. I know my colleague, Dr. Yosipovich, has been a big champion of that, and of course, other atopic derm experts. And really, but some of us can't really afford or have the resource like an eczema school because a lot of this has to do with educating the parents. So maybe you can share with us some pointers on this, on how to approach parents who, as I mentioned in my introduction, may be very scared. It's maybe their first child, first time they even hear this diagnosis. How do you approach that education part?
So the first thing, speaking efficiently, I'm the only provider in my practice. I usually don't have anybody who's helping me to even room the patients. So efficiency is really key for me. Initial intake questionnaires are exceedingly helpful, both for grabbing the information such as the poem or any pieces that we can kind of get a glimpse into the severity with kiddos, but really further understanding what families are coming in with their treatment plans, their ideas of what they may want to do for management is a key question on my intake form, as well as just blatantly putting it out there. Do you have any fear with any medications that you've been prescribed before? So I think that all of us can relate that a common theme for treating infant eczema these days is topical steroid phobia, the worries about withdrawal and TSW and things of that nature. So I think really for me, being able to have an efficient appointment where I can see in a snapshot through this intake exactly what treatments they've done, what types of products that they're using, family history, how it's severely affecting possibly quality of life, and then just blatantly, what medicines were you hoping to do? What medicines maybe you're worried about? And that really helps to kind of like put my game hat on. What are we going to be talking
Yeah.
about? We're going to be talking mostly about foods because the parent wrote a whole paragraph about the foods in
Right.
the
Right.
child week by week. Or you can just see very plainly on the form, like, no, I'm not worried about topical steroids, and they haven't used anything at all. So I think that that piece really kind of is that jump start to knowing what type of visit we're going to have.
Yeah, and I think that's very smart to actually address head on some of the treatment concerns that parents may have and kind of putting that straight up in the questionnaire, because we all have our little forms, but I think that's pretty innovative to actually attack the management part head on, so that, like you said, it gives you a leg up and makes the visit more efficient. I love it.
Yes, yeah, it exceedingly saves me time. I don't really want to know about which neighbor asked you to use this cream that you can't remember the name of. Or I know, God knows, all of us have heard, oh, well, it's the white tube with the green line across it. I have no idea what that is.
Right. No, absolutely. And it is a challenge sometimes, especially in that first visit. Usually, some parents are able to bring a bag with the medication. I'm so grateful for that when they do it, but I know that it's a schlep. But I tell them just, take a picture. Everything you have, just put it all in one area on the table and just take a picture, and we can work magic with just that one picture. I love it. And so what else do you do for parents' education? Because now they're kind of in the room, they filled a screening form, and you have it in front of you. Any other nuggets, as you call them?
Yeah, so I would say after that point, I'm going through and assuring the family that I did actually read their intake. I'm pointing out key areas that may be red flags for discussion, but a lot of times that jumping point for discussion is the family history question. Oh, I see here that dad has a history of sensitive skin. We know that families often do have eczema, allergies, asthma. Doesn't mean that your kiddo is going to have all of these things, but we're made to be genetically sensitive. So we all know that families really want to talk to us about food allergies, food sensitivities, root cause, and how foods may be flaring. However, we need, in my opinion, we need to really balance the message of the translation of what we get to learn as healthcare providers. We know that family history is going to impact people who have atopic dermatitis to have easier, skin barrier breakdown, which allows those antigens and allergens and irritants to get in and cause the chaos and that cascade of that inflammatory process that can become very chronic, and allows us to really know what types of medicines we may use according to the chronicity or not. But I really feel that that jumping off point leads into a discussion using an eczema action plan that helps me to show the families that I am aware of all of the medications that I have currently available for the age of their child, but we're going to talk through and really kind of literally click boxes. I have a TV up in my office. I do the, shared screen, move that eczema action plan up so that we're all viewing it. And then we're customizing and we're choosing the medications for when they're flaring or not flaring. And through that whole kind of process of what have they used before? Oh, you've never seen the name of this medicine before. This is why I have this there. Maybe we're not talking about a medicine that is a non-steroid, and explaining to it for specific reasons. Maybe they've not used any medications at all. So that eczema action plan really helps to first guide me. Maybe I'm having the case of the Mondays and my mind's all over the place. It really helps to guide me back into the important pieces that I want to educate my families about. And honestly, a majority of my families, by the time that we're done going through the green, yellow, and red zone, the particular products that I want them to choose, getting over the fear of what a bleach bath is, and yes, I do want them to put a dilution of water and bleach with their baby, possibly, then sometimes they have really no questions, believe it or not, by the time that
Right.
we're done.
Yeah, and I agree with you, because I think that when you do that piece well, and I feel really rewarded as a clinician, and regardless of the disease, when I give a good kind of explanation, I say, any questions? And I see on their face, no, I think I really got it. And you can tell on their face that they actually got it. But I wanted to ask you, Sam, because you bring up the eczema action plan, maybe you can just, for our listeners who may not be familiar with this, what do you mean when you say that? Where can people find it? If you give just an overview of what that means.
Yes, so eczema action plans were derived from the concept that are very akin to asthma or seizure action plans. The green zone in this case is when the child is doing well. So I label that area the non-flaring zone. When you're not flaring, there are still key products that we need to use on the skin to help to build up the strength of the skin, reduce irritants, keep the skin pH in the healthy level that we want it to be. And then in the green zone are also our maintenance medications. So that's the discussion point of maybe you do have a patient who has a topical steroid phobia, but maybe the patient's really never even used a medicine like a topical steroid. And so you want to kind of trial and see, like, if this patient only needs a topical steroid like 1 day a week, and so cumulatively they're only using it 4 days out of the month, I'm not going to worry about a patient, number one, overusing, and maybe that's the right treatment for them, and we don't need to get into maintenance meds. But that green zone will house all of your maintenance medications that you would use. Maybe you're also a provider that wants to pop in some of the topical steroids for maintenance. And then an arrow has qualifiers, and those qualifiers for getting down into the yellow zone is that if you have red, itchy, bumpy skin, now you're in the yellow zone. That's the flaring zone, the treatment zone. And then it's all of the instructions that they would do when they have a flaring area. So you start using ointments instead of creams because you explain that the creams are preserved with alcohol. It stings. You have practices that can help reduce inflammation naturally. Patients really love to hear that. So the bleach baths, the chlorine pools, the hypochlorous sprays, those are the things that we're talking about when you're in the yellow zone. And then obviously the discussion of the medicines. You have the locations written out on the body part with the particular medicine that you're going to use in that area, reminding them that if they are using a soapy product in the green zone, in the yellow zone, they should be thinking about either a liquid cleansing or a cleansing bar. And then if there is risk for skin infections, which we know that happens with our AD, especially our babies, then just reminding them, like if you have this antibiotic ointment and you're seeing signs of infection, if you've already been doing the bleach baths or the hypochlorous sprays and you're still seeing the skin continue to not get better and have signs of infection, then I do counsel them, like, you may expect to have to use this once every month if it's a bad flaring time, or once every couple of months, hopefully not a whole lot. And then the qualifier to get back up into the green zone is when the skin is clear or almost clear. So then this is all done in a Word document. I have permission to use the Bristol Universities from the UK, actually, where they do really good eczema management there as well.
I see. So, and that's what you meant when you said you have a TV screen or the computer kind of open in the office, and so you type this as you go through the visit.
Yeah, so you definitely have that template, and you just have boxes that you're clicking, and then you at least have the freedom to mark up and change if there is something particular for that patient, or maybe just a medicine that's not normally in your template. The formatting is only going to allow a certain amount of space, but yeah, and then you doctor that up, send it to the patient when you're done, and patients have such confidence when they leave the appointment that maybe they're jiving with you and they're understanding the education, but you know that they look like a deer in the headlights by the time you're done with like 10 minutes of education. So at least you know that you have reassurance, they have the treatment plan. I also never, honestly send more than the 1 tube of medicine because I explain to them that's a safety mechanism for me. If you do need more medication, just reach out to me. I'm really easy to get by text. And when you're done with that prescription, that may be like a few months down the road. If you're using and milking that amount of medicine for 3-6 months, that tells me you're not overusing that amount. But then that's a time to look at the skin and see. If you're worried about the medication side effects, then let's go ahead and have an appointment together to see if that's a problem after you've used the treatment. And if it works, obviously.
And Sam, what you're describing doesn't sound like it takes too much time. It sounds like what you will be doing anyways. You'll be documenting, educating, describing the treatment, the disease anyway. So it sounds like it's a nice way to kind of guide the conversation make sure that you don't miss anything and then have a nice little product at the end of it. So the Eczema Action Plan, my friends, that's really cool. Sam, I wanted to ask you, so now the patient's been in your practice, you kind of educated the parents and they got the action plan, they're going about their way, but maybe they come back. We are now in a really amazing era when it comes to atopic dermatitis with new medications on the market, some of them complex with different mechanisms, a lot of research coming out, and then newer medications are still coming to the market with new research and data that keeps pouring in. How do you reconcile this for parents that come to your practice, either with new information that you want to introduce or even existing information on that first visit? How do you introduce all this new data and studies and research when it comes to bringing it down to the patient in front of you?
Yeah, so I try to explain to families in a way almost like layering. I explain that the top level of the skin, we're going to be using particular products just to help to strengthen the skin. That's where the immune system at that skin level with use of topical steroids is effective. However, when there's more of a chronic nature of that eczema and those messenger cells keep sending off the alert messages, then maybe we have more of an issue deeper down. So that's when I'm going through the green zone of the maintenance and saying, tacrolimus, Zoryve, Opzelura, whatever age of patient that I'm seeing, maybe we're thinking about a little bit deeper at that cellular level. And then when we need to get down to what I call the highways of our inflammatory processes, then we're thinking perhaps about Dupixent. So I kind of layer it for them, which can be challenging because I don't necessarily put Dupixent as like, oh, you're severe, you're the most severe, now we're going to use this, because I think there's such applicability in a moderate patient that doesn't need to step through everything if insurance doesn't require us to. But I do try to explain to them at least a little bit, like not necessarily saying, oh, this is a PDE4 inhibitor, or this is a JAK inhibitor, or this is a T cell, but letting them know that there are reasons why patients keep cycling. And if you come back for an appointment and there you are flaring right after the steroid has come off, and this is a chronic thing for you, there's really no risk factors in your life, no soccer, constantly outside with grasses, no kiddo that's sick frequently, you stop that steroid and it wants to come back, then we get a little bit into that discussion at an appropriate level for MOA and how there may be some of that inflammatory process that's revving up too much, and we got to break that cycle. And families tend to resonate with that, which is why I really love to try to translate the MOA, and anytime that there is new research, helping them understand the age and sometimes the challenges that we have, because these companies can only study down to 2 years or so. And so when I see patients who are 6 months on average, it does become challenging, but that piece is more so the hope at the end of the tunnel. We are going to be doing these things at first, but once your kiddo gets older, then there are other medicines that we could think about, because we naturally would be trying to transition away from the steroids to these meds too.
Yeah, and I wanted to ask you, because you have this action plan, you mentioned your intake form, and you mentioned parents a lot of times in this information age come in with already preconceived notions of certain treatments that they want, or maybe they are really afraid of a certain medication or really want to use a certain medication, but then you see them and in your opinion, maybe it's not a great fit, right? What you had in mind, you heard a commercial, your girlfriend said, oh, my Tommy used this cream, was spectacular. And then you look at the skin of their kid and you say, I don't think that's a good fit. How do you go about offering these alternatives that maybe you have in your toolbox that you consider are more appropriate? Especially, again, we were talking about parents, very nervous, new kid, don't want to try new things sometimes. How do you go about that proposition of an alternative?
I try to help families understand risk of contact allergies, number one, which I think gives myself and other providers validity, and like we do really truly think about what I'm asking you to use on the skin. So I do kind of a quick summary of why a ceramide-based product may be better hydrating the skin than any other product. And then on my action plan, I say, really, when your skin is flaring, avoiding fragrances, botanicals, and foods when open and flaring, because the skin is the largest organ in our body and it's absorbing everything that we put in it. We don't accidentally want to be sensitizing patients to plants and foods. So I feel that that discussion will kind of help, because that is not information that a lot of families have heard of. Most families do not know that lanolin is a very common contact allergy, and research is showing us that it could be causing maybe a little bit more of that dysbiosis or hostility on the skin than we give it credit to. And then I let them know, well, when you are looking at two different products, why don't you think about choosing a product that actually has some research to show that it's repairing the skin barrier at a deeper level? So you should be thinking about a product that has a ceramide or literature to back up that it will be hydrating the skin. So if you have this glitzy, new, trendy product and there's really no data that shows that it hydrates other than just the cute marketing that they have, I think that that helps to kind of steer them into what types of things I want to choose. And I feel that because, unfortunately, I end up being the very first person that's talking to them about lanolin, ceramides, creams, sting because of alcohol content, that trust in my knowledge with AD, and really a consideration and hearing that they see these problems and validating, yes, you would have seen your kiddo maybe react negatively from a simple, even a CeraVe cream. But was the skin flaring? Were they screaming because of burning? Well, guess what? There's alcohol content in all creams. So I think that that discussion early in the appointment will then help if we need to get into, well, I know you don't want to use a steroid, but we're going to talk about this because of what we see or the lack of treatment that you've done before. So I think that, again, if you have that action plan, all of the products, I have pictures in the green and yellow zone, and once you've had that discussion, it really allows them to think like, oh, she does know what she's talking about. And then they're more open to different alternatives if necessary from what they wanted to do.
Yeah, and it really all kind of comes nicely together with the action plan, the intake form, this kind of all-in approach that you have, which I really appreciate, Sam. Hey, thank you so much for joining our program. This was a really great discussion and a lot of really helpful tips for any practitioner who sees parents with very young kids learning about atopic dermatitis, maybe for the first time, trying to explore different treatment possibilities. So thank you, Sam. And I hope that you get to see many kids that are nice and smooth with an action plan that's been fully accomplished. And again, for those of you who didn't catch it, Sam Casselman is a pediatric nurse practitioner, and she's in Arizona. If you want to look her up, just Google Happy Skin Pediatric Dermatology. That's her practice, and that's all for today. Thank you, Sam.
Thank you so much, Adar. Have a great day.
Folks, we'd like to invite you to check out our colleagues in the dermatology podcast family, Dermosphere.
Luke and Michelle are two board-certified dermatologists who also discuss the latest research in the world of clinical dermatology. Learn about recent drug trials, disease pathogenesis, off-label drug treatments, and more.
Come for the dermatology, stay for the dad jokes. Dermosphere has been around since 2019, and I just love seeing how they grow as part of our podcast community. Search Dermosphere wherever you find your podcasts.